Limb injuries are not life-threatening unless there is excessive bleeding. That means treating them can wait until you've completed your primary patient assessment and physical exam. This is true even if there is great pain or deformity in a limb injury, which usually indicates a broken bone or fracture. When you begin the treatment, compare the appearance of the injured limb to the opposite limb. Look for an open wound, deformity, swelling, bruising, and the patient's inability or willingness to move it. Gently feel the limb for points of tenderness which indicate a fracture, dislocation, or sprain. The spot that hurts the patient most is probably the injury site. If even slight motion causes pain, no further motion should be attempted. Next, it's important to evaluate circulation and sensation in the injured limb. Check the radial pulse or ankle pulse and capillary refill. Then test the patient's ability to feel your light touch on either the tips of the index and little fingers or on the tip of the big toe and top of the foot. All limb injuries should be splinted before a patient is moved to prevent additional pain and injury.
Rigid splints are made from firm materials like wood, aluminum, or plastic, which are padded for comfort and are applied to the sides, front, or back of an injured extremity for rigid stabilization. Soft splints are often made of inflatable plastic and are used to provide uniform pressure to a bleeding wound. When standard splints aren't available, you can often improvise. For example, a rolled-up newspaper or towel bound by a belt will do in a pinch.
Choosing which type of splint to use depends on the location and nature of the injury. Refer to your textbook for specifics. Splint the wound in the position you find it. And remember that most splinting techniques are two-person jobs. One person stabilizes and supports the injured limb, while the other person applies the splint.